It's a pleasure to introduce Pierre Lavertu. We were discussing whether I should use the French pronunciation, but I thought better not. From Cleveland in Ohio, and Pierre is going to talk to us about the management of persistent and recurrent neck dissection. Thank you, Pierre.
Thank you. Now I know why he knew the first name of the custom person. Good morning, everyone. My job today is to talk to you about the management of neck after chemoradiation therapy. I have no disclosure except that I work for that institution. I'm sorry, that's not working. What are the options that we have in the management? This is not functioning the right way here. Can we go back to the beginning, please? Okay, thanks. Let's talk very briefly about trying to do surgical salvage on neck recurrence. This is historical, but historically it was hard to diagnose. It was often unresectable at the time of diagnosis. If it was operable, it was rarely successful, and basically very few people survived that intervention. And just to show data on that, this is data from University of Florida, historical data again, where they were treating patients with radiation therapy alone, and they had an incidence of recurrence of 14% when they had N-positive neck to start with. And of these, a third could be operated on, the other two-thirds could not. And of all the ones that were operated on, none survived. So this is what we had to work with. So that kind of gave us the incentive to do something else. And so what should we do after we've treated patients? Well, I think everyone agrees that surgery has no place in patients that were originally stage N0 and 1, assuming that there was no tumor progression and there was complete response. And then we had two main category of things, which was a planned neck dissection, where regardless of the response, you just go ahead and do it. Or you wait, or you identify recurrence or persistence, and you go ahead and you treat it. So let's go and look at all of this. A few years ago, we ran a randomized trial at my institution whereby we had 100 patients and they were randomized to radiation and chemoradiation. And of that group of 100 patients, we had 53 patients that had N2 and 3 neck disease. And you could see that some were complete responders and some were not complete responders. And we were assessing this clinically at the time, because our philosophy at the time was to do a planned neck dissection. And all the numbers matched, okay? At about 6 weeks, we would do a planned neck dissection, and we found positive pathology in about 25% of the complete responders, and of the ones that didn't have any neck dissection for XYZ reason, we found recurrence in 25%. So that all supported our data. Furthermore, in that paper, we identified that the benefit of a neck dissection was not obvious, because there was better survival in patients that had no dissection than the ones that had a dissection. And we also identified that disease-specific survival was related to the presence of a positive tissue in the specimen. And this has persisted in numerous papers over the years. The only thing that the neck dissection basically did is that it reduced the incidence of neck recurrence. It didn't take very long for people to realize that to do a neck dissection at 6 weeks was probably not totally reliable, and especially the pathology of a neck dissection at 6 weeks is definitely not reliable. Dr. Hanna, at the time, just after he started in practice, conducted a study, and they basically elected to only operate on the patients that had less than a complete response, and basically they achieved a neck control of 92%. And more so, they identified that in the patients that had complete response, there was no difference in survival in the ones that had neck dissection and the ones that didn't. So how could we identify the patients that should have a neck dissection? So people started looking at other modalities instead of doing a neck dissection on 100% of patients. Maybe there are ways that we can identify disease or persistent disease. And CT was the first tool that was used for that, at least in this country. And this group, again at the University of Florida, they were looking at CT scanning at 4 weeks, which we would argue is probably not the proper timing, but at the time that's what they had chosen, and they had criteria that were pretty specific. And they correlated that with the pathology findings because they were still doing planned neck dissection at the time, and they also compared it to clinical exam. And you could see that the negative predictive value of the CT scan at 4 weeks in that population was 94% negative predictive value. What's interesting also is to note, and that goes on papers and papers and papers, is the positive predictive value of CT is not very good. You have probably only 35–40% of patients that will have disease histologically. So they also identified that they had some patients that never had a neck dissection and were complete responders. They compared them to the ones that had a neck dissection, and basically they had 100% neck control. And basically they concluded that we didn't need to do a neck dissection for complete responders on CT. So basically all my pretty work was really questioned by a lot of people. And MD Anderson, at the time Dr. Peters was there, they had a series of oropharyngeal patients, 100 patients. They decided that they would do neck surgery only for the less than complete responders. They had 75 patients that had no prior surgery. They had 57 patients that were complete responders, and only 3 of those recurred, and 1 was able to be salvaged. So they figured that for a 5% failure rate, it was not justified to do a planned neck dissection for that, again, patient population. Dr. Peters moved back to Australia and then came up with this study where they had 102 patients, and now the evaluation with CT scanning was at 12 weeks. I guess over the years people have realized that the 6 weeks or the 4 weeks was too early, and that 12 weeks is a better evaluation. And again, this is based on CT scanning. You will note that there were 60% complete responders, but there's 40% of the patients that were less than complete responders. They never lost in the neck as the only site of failure. But they were still doing neck dissections in about 40% of their patients. And then came the PET scan, the new kid on the block, the expensive one. And Dr. Yao, who was a radiation oncologist at my institution at the time, was at Iowa, had a large series of 174 patients with a negative predictive value of 99% for lymph nodes and a positive predictive value of 70%. So just a few cases to illustrate that. Unfortunately, I cannot point on both screens at the same time, but you could all see on the CT scan on the left that there is an obvious persistent mass, which is negative on PET, which is next to it, and this patient had a neck dissection and had negative pathology. Does that work all the time? Obviously not. This patient had a negative PET at 12 weeks, but then recurred a year later in the same location. There was also studies that were carried could you move forward the slide, please? Our colleagues in Ontario conducted a study comparing CT with PET, and basically this was a negative study that led them to conclude that there was no advantage in PET over CT, but this is one of the only studies that I found about that, and I haven't seen any publication on that, so I'm not quite sure what happened, but their negative predictive value of PET was only 73%, which goes against most of the results in the literature. Our colleagues in Australia kind of did a variation on a theme where basically they compared CT with PET. The way that they report, they structured it in a way that they would do the CT first and divide the patients with complete response on CT in one group, and the one in the gray would be the ones where there's less than a complete response, And basically, if you had a complete response on CT, all the PETs were negative, and none of these recurred. And if, on the contrary, if you had a positive CT, then you would do a PET, and the majority were negative on PET, and the ones that were positive ended up being operated on, and these were the only ones that had cancer. This is a very exciting trial. When I saw that, you go from one extreme to the other, and I just asked Dr. Mohana, who conducted that trial, how in the hell were you able to do that? And the reason that he was able to accumulate 560 patients and randomize them between neck dissection and PET-CT was because neck dissection was his routine at the time. That was the standard of care in this country, to do a neck dissection. They must have read my paper at the time, probably. So this, unfortunately, is not out yet. There will be an amazing amount of data that will come out of that. I'm sure it's going to show that PET is better, but it'll be very interesting to read. And they did it all the right way. I mean, they're evaluating it at 12 weeks. Please advance the slide. Again, they randomize them to PET versus the neck dissection, and they assess with imaging at 12 weeks, and the same with the neck dissection, I assume. And it'll be very exciting to read this. I don't want to go into that too much. People have talked about using ultrasound to biopsy positive PET findings. It is not totally reliable, and I think most of us would probably agree that nowadays, after chemoradiation therapy, if you need to do a neck dissection, you will do a selective neck dissection, levels 2, 3, and 4. Just to talk a little bit about imaging for surveillance, there's a lot of things that we can do. I think it may be good for detection, but there's very, very little evidence that it does impact survival. So in concluding, is we have a bunch of options for the management of the neck after chemoradiation, and part of it has to do with your means and what you have available. If you're going to do a planned neck dissection like we used to do in the older days, you're going to do a neck dissection on 100% of your patients, and only 90% of them will probably not need it. If you use your hands and you just do it on the ones that have less than a CR, and I would again stress that you need to wait 12 weeks to assess for that, you will do a neck dissection in about 70% of your patients. If you use CT scan to evaluate that, you will end up doing a neck dissection on 40% of your patients, so a bunch of them are not going to need it. If you do use the PET scan, either after a positive CT scan, which may be a little cheaper than do a PET scan on everyone, you will identify about 40% of patients that will need a PET scan, and then on the PET scan you will identify the ones that are positive, and then you will cut down on the need of neck dissection to probably less than 10%. Thank you very much.